Joining us for this very special session that we have today. For last 2 days, we have had very enriching sessions with the best experts in the country to deliberate on scientific sessions, advances, recent developments that are going to transform the cancer care in the world. But somebody has to make it happen. And the business leaders, I think they play a critical role in providing an ecosystem to foster innovation, provide collaboration, and actually set the direction for the healthcare organizations and to a larger context, set the direction for the country. And we are very privileged to have a very august and very eminent set of healthcare leaders today. With further ado, I would like to welcome Mr. Dilip Jose, Managing Director and CEO of Manipal Health Enterprises Limited, an integrated healthcare service system with 33 facilities and over 9,500 beds. Dr. Om Manchanda, Managing Director of Lal Path Labs. He's worked across multiple companies and successfully transformed Lal Path's lab. Dr. Ajay Kumar, medical oncologist, doctorpreneur, thought leader, and executive chairman at CG Group. Dr. Ashutosh Raghuvanshi, managing director and CEO for his healthcare. Dr. Vineet Datta, who brings together an experience of 20 years in patient care and is the executive director at Datar Cancer Genetics. And to moderate it all, we have a very special guest with us, an award-winning journalist and editor with CNBC, Ekta Batra. Thank you.
Hi, good afternoon, everybody. Thank you very much for joining in to this conference. Well, we are going to be discussing a topic which is extremely relevant to India as well as the globe, and in this prestigious conference and very relevant conference, which is sponsored by Fortis. So before we start, I just want to put some statistics out. 1 in 9 people are likely to develop cancer in his or her lifetime in India. India ranks third after China and the US in terms of new cancer cases. Only 30% of cancer patients survive 5 years after diagnosis in India, and the household out of pocket expenditure of healthcare, though it's improved to 48%, it's still lower, it's much higher than the global average of 18% as of 2019. So, this is where India stands in terms of healthcare expenditure. We also have some other statistics. India has the second highest rate of oral cancer cases worldwide. 1 in 28 women in India are likely to develop breast cancer in their lifetime. Cervical cancer is the third most common cancer in India with an incident rate of 18%. These are just a couple of statistics to put into perspective the cancer burden that the country has. So without further ado, I'm going to bring in our panelists to discuss this problem and the way forward and where exactly does India stand. Thank you very much for joining in, gentlemen. Dr. Raghuvanshi, let's open up the panel with you. Why exactly do you think India has such a high cancer burden?
Thanks, Ekta. I think in India we are exposed to several environmental factors which probably contribute to this. Air pollution, pesticides, antibiotics indiscriminately, etc. Plus, on top of that, there's a lot of prevalence of viruses in the environment, and a lot of scientific papers suggest that inflammation could be one of the precursors of cancers. So I think that's how, because of the environment, it happens. And that is why I think it is very important to understand that the prevention is not only about tackling the disease directly, but also looking at the hygienic factors around. And that is why the public health engineering budget also, in my view, should be considered as a healthcare budget.
Okay, fair enough. Dr. Ajay Kumar, you're an oncologist, you do practice actively. Can you tell us why exactly does India have such a high cancer burden? Yes, we have progressed a lot in terms of treatment, and we'll get to that in just a bit. But we do have some of the highest cases. Our burden is rising. We are lower as compared to other countries. So give us a sense in terms of what the structural systemic issues India faces when it comes to cancer.
Yeah, I think regarding the cancer burden, as we know, unfortunately, we are seeing higher, but compared to the Europe or US, the statistics we have, I'll come to that in a minute, is still not there where we are. We are still lower. Now, like one in maybe 9 people getting cancer compared to 1 in 5, 7 in US and Europe. But having said that, one of the things we lack in India compared to the more advanced countries is a national cancer registry, which I think it's very, very important, crucial. And I think this is where we have to bridge the gap between the rural and urban India also. Understanding the real incidence of cancer and what are the types of cancer and what stages they come will help us a lot to really take it to a next level of more prevention, understanding prevention, then going on to in terms of what should be the early stage cancer treatment, where our outcomes will be very good. But what is happening now is, for example, you take rural India, we really don't have an idea what is the incidence of breast cancer. It is quite possible the breast cancer in rural India is far lower than urban India. Whereas cervix cancer may be more, but it is dropping quite significantly. So, how we allocate our resources also becomes very important. For example, what is the point in having mammography units in rural India if it is incidence is low? So, whether we should do more of that in urban India, because breast cancer is a lifestyle disease, any cancer is, and women in urban area because of their lifestyle eating habits or we are going to see more 1 in 4 in future maybe breast cancer 1 in 5. So how do we take precautionary measures now? How do we teach the population so this won't happen? So we learn from the West the mistakes they have done. Similarly, why we should focus on certain rural areas, more focus on maybe vaccination and bringing down the incidence of pretty much cervix has been eliminated in the West. Pretty much. Why can't we do that here? And oropharyngeal cancer. So it is, we are at crossroads in India. And one of the things we always talk about is India as a whole. But I believe we have to segment India into affluent India and not affluent. And affluent India itself is as big as United States. How do we address that? How do we address the non-affluent and bridge the gap? So this is the challenge, and this is where private, public have come together to play a role. And unfortunately, that has not happened to the extent we want.
Dr. Dattar, what about you? Why do you think India is where it is when it comes to its cancer burden, the statistics that we spoke about when it comes to cervical cancer as well as head and neck cancer?
See, the problem that we face is on multiple fronts. One is that we're lacking early detection across cancers where there is significant amount of evidence to suggest that that can have an impact in terms of early diagnosis, better outcomes, positive impact on cost. And when you look at across global metrics, whether you look at breast cancer or cervical cancer or lung cancer or prostate or colon, where there is sufficient evidence to suggest that screening needs to take place, we're not there. So one challenge you have within the ecosystem is that we are detecting cases far too late. Hence, the problem with our system is navigating rather than curative, but is to minimize spread or further expansion of disease. That's one element of the problem. The other problem that you have is more fundamental, which is the fact that you really need to rethink for a country like India, the dynamics that have worked overseas may not work here. And for that, the primary element of the change I'm seeing across at least the oncology community now is that we are starting to gather our own data. The genomic space which I come from, data was established years ago to suggest that how Indian patients behave, for example, in the lung cancer space in genomics is very different to the West. Why would we then follow their guidelines rather than build in our own guidelines basis the data that we have as part of that ecosystem? The second problem that we have is with regards to access. So access, this rural versus urban divide is one element of that process, but that's largely again been driven by education. It's only been in the last 10 years we've started to see positive influences, for example, of things like, for example, basic things like sanitation. We're talking extremely high level things at the minute, but you've got to fix the basics. You've got to have housing, you've got to have clean water. Those are things which will impact infant mortality. They will impact women's health. They will impact the outcome in terms of some of those diseases, including cancer within that space. And I think lastly, more importantly, we've also got to look at within the ecosystem of education, please understand screening and early detection is always a behavior change. Never happens overnight. This needs culmination of decades of sustained effort to make those things happen. So when you have things which are preventable within the space as a country, if I cannot prevent the preventable, for example, an HPV vaccine for cervical cancer in women, where uptake for screening is less than 10%, it's a serious problem. And I think we were discussing this just before the panel started. When you look at healthcare, and healthcare budgets are, well, they're way above my IQ, but you really need to have a CXO at the level of the health ministry to look at oncology as a separate domain. You're a young country today. You are a young country today. Please understand the dynamics of economics in the West, where we have trained, the majority of us have trained, those systems are falling apart. Patients are living longer. There's a higher cost element to that treatment that needs to be provided. Somebody's got to pay for it. And if it's a public healthcare system, it's draining your resources. And in 20, 30 years, we will not be that younger country. If we are thinking only till 2029, it's a different story. But for those of us who want to lay down the foundation for this country in terms of improving healthcare dynamics, oncology is the new cardiology in town. You have to invest into oncology, and that has to be driven through prevention and early detection. Treatment is another dynamic which I'm sure we'll discuss today, but it has to be the focus of looking at a sustained strategy which does not move from one budget to the other, but over a 2-decade plan. What do I want to achieve as a country in 2035? Where do I want to be in oncology in 2045? You define those metrics and then you put action plans in place which are sustainable, which are cross-government. Doesn't matter which government comes in. But you have to build in those programs, and it has to be built in through the foundational element of that process. It may sound utopia today, but if you don't do it today, in 20 years, we're in a shitload of trouble.
Okay, well, I'm sure we're going to have a lot of questions towards the end of the panel, and I'm going to open it up to the public. But Mr. Manchanda, you've been conducting tests across the city, and this is something that we spoke about the India rural and urban divide. Based on the data that you've probably seen through clinical testing, what is the difference that you see which stands out in terms of what is taking place in urban India vis-a-vis rural?
Yeah, thank you. As I'm preparing for this panel discussion, I've done a lot of data analysis as well. So maybe I'll share something which is based on our internal data, may not be representative for the country. I actually couldn't find much divide between rural and urban because most of these samples that we get are collected from hospital setup. And many times we don't know where that patient is coming from because the sample is being sent to us from a hospital.
Or maybe even if the trend that you've seen in the past 10 years.
Yeah, so few data points I'll probably share that the number of samples that we get, about 15 to 16% cases are positive for cancers. 16%. So if I get 100 samples, nearly about 15, 16 are positive cases. Interesting thing that I found was that the gender split, male and female, is nearly equal. But what is actually a very sort of startling or worrying factor that I found was that more than 50% cases are below the age of 55. Now, you can attribute to this whether it's getting early diagnosis or the incidence going up. I really can't make that out. Another thing that I noticed that females are nearly cases which are positive between 36 and 55 years of age, 60% are females. Now, I think the question that you asked to earlier panelists is what is causing, and the most fastest sort of growing cancer that I find in our system is head and neck. And it's very clear that lifestyle factor, this whole tobacco is biggest reason for that. And pollution, the environment itself is causing. So in my view, I think we are discussing about treatment and diagnosis. I think we need to discuss more about what is causing it, and attacking that is very, very important. So to me, I think head and neck is number one cancer that I see, at least in our data. On urban-rural divide, I think one can safely assume that rural cases are coming in advanced stage, urban are getting more diagnosed early, mainly because of facilities that are available. So as of now, I probably don't have firm data to share in terms of what is the divide between urban and rural, because most of them are actually getting picked up in urban setting.
Anything specific that you've noticed in the past 10 years in terms of a decadal change?
Yeah, I think that's an interesting question. I think this whole COVID has caused a bit of unevenness in the data flow. I'm not seeing in terms of very high rise of cases being sent on diagnosis. But one trend that I'm seeing now is that it's not just histopathology, because a lot of these advanced testing like IHC or NGS, typing of cancer has become very common test in terms of finding out what is the line of treatment doctors need to follow. I think those tests are actually on the rise.
Mr. Dilip, you have hospitals all over the country. If you could give us a sense in terms of, say, the trend that you've noticed in the past 10 years, and whether you have any kind of sufficient data to assess this divide that we're talking about when it comes to urban and rural, because while we talk about affluent, and I'll come to, the out-of-pocket expenditure, the rural part of India also suffers from a cost burden.
Yeah.
So is that one of the reasons why you see them coming in late? The trends that you've noticed, urban, rural, as well as maybe in the past decade or?
Thank you, Ekta, and pleasure to be here. Thank you, Dr. Raghuvanshi, for asking me to join you at the summit. Good afternoon, everybody. I'm probably one of the rare non-doctors in this room. I think Ekta and I, maybe one or two others. And I must say, from the time we started the pre-panel discussion till now, it's all been depressing statistics. It sort of feels good to be alive at this point with this kind of statistics. We are all glad that we are alive in this room. That's a sad way it is getting portrayed. But having said that, in the Manipal system, I have my doctor colleagues, several of them in this conference. What we find is that about 10% of all the patients that we see, we admit and treat, are for some form of cancer. And it is increasing, the trends are increasing. And like the learned colleague said, part of it would be on account of this increase in capabilities of diagnosis, whether in rural area or urban area. The increase in capabilities of diagnosis is sending more patients to seek treatment. The second one would be, at least in the early stages, there is an increase in insurance cover and increase in affordability that is allowing people to sort of access treatment. These two are important trends. But what we notice is that lot of maybe 1/3 of this patient that we are treating are from out of geography, so to speak. People who are not in the normal catchment of our hospitals. We got 33 hospitals across the country, and most of them do have oncology facilities. And what we see is that 1/3 of our cancer patients are from outside of the geography. So, Ekta, to your point about the cost, what it means is a lot of patients are traveling over distance, long distance to access treatment. And in that case, the cost of treatment is not only the hospitalization cost, it is the family who accompanies them, their logistics cost of staying outside. So pretty soon it becomes completely unaffordable. The one sad part about insurance is that while there is a growth in insurance and increase in number of people with insurance, from a cancer treatment perspective, the coverage is often inadequate. The doctors in this room know that even at the cheapest of kind of setting, it would cost 4 or 5 lakh rupees. And Dr. Ajay Kumar was talking about earlier, breast cancer treatment in India today costs about 6 to 8 lakh rupees. And an average healthcare insurance cover for even for a middle income family is 4 or 5 lakhs per year. So you run out of that, the coverage pretty soon, and then you can't stop the treatment midway. One unfortunate pattern that we see is that people discontinuing treatment, discontinuing chemotherapy. Maybe if they are prescribed 10 cycles, maybe after 4 or 5 cycles they said we can't do. And it is a horrendous situation for me as a manager, and even more heartbreaking for doctors who are treating them. So this is one trend, Ekta, that we are noticing.
So that is actually a very important trend. Dr. Raghuvanshi, I'm going to get you on board for this. Out-of-pocket expenditure, 48%. And even if you talk about, outpatient expenditure, cancer is a majority component. Inpatient expenditure, cancer is a majority component. Insurance coverage, while it's rising, it's still rising. It's not covering, majority of the population at this point in time. So a lot of people actually get into poverty when they actually come for cancer treatment. And the best cancer treatment, whatever that might be, is only mainly available in private settings. From that perspective, what do you think we need to be active steps that need to be taken in order to probably solve this issue?
Yeah, as Dilip was pointing out, I think the inadequate coverage of insurance is the major problem. Because the total cost of the treatment cycle, it is not an episodic treatment, but it is a treatment which goes over a period of time. So that is the major problem. And I think there are multiple things which need to be done. There are direct measures which need to be taken. One is to see whether there could be some critical care coverages, which some of the insurance companies have already started offering. So that is one sort of safety guard which people can have. But that again increases the cost in terms of premium, but at least it prevents a catastrophic situation for the family. So that is one thing which should be encouraged in my view. Other than that, I think early diagnosis is the key, because the cost of treatment as well as the outcome matters a lot at what stage you start the treatment and how early you start it. So I think there should be a lot of focus on that part. So these are the two main measures, I think, which can be taken.
Dr. Ajay Kumar, come in on this, because you probably have a lot of people who you see also retracting from treatment, or their treatment goes on for years and they have maintenance costs also which come through. And many of the times it is the head of the family who has cancer and is not able to provide for the family, so the burden just increases. So in that vicious cycle, what do you recommend to a patient? Is there public infrastructure which is sufficient enough to probably help in terms of balancing that out?
Yeah, it is, essentially in India, unlike in US, where I never worried about the cost. The patient comes, we do what is the right treatment, because most of the insurance covers. And one of the most important thing, like in US, like what Dilip mentioned about a limit, there are no limits. See, I am myself a Medicare recipient. I can go to any hospital in US and get free treatment. No limits. But unfortunately in India, we don't have that kind of a limitless universal healthcare, which we have all been fighting for. But at an individual patient level, the dilemma as doctors we face is essentially, we know what is the right treatment to give. Suppose there is a 25-year-old patient who has limitations, scheme or insurance, but I know the treatment she requires for a breast cancer, which could be long-term control, involves using expensive medicine. How can I deny this? Morally, ethically, I cannot deny. Knowing, you cannot say you can't afford, I won't do. So it really comes down to what is the awareness the public sector has about it, why they don't approve certain drugs, it is a constant battle for doctors. Now, doctors are also financial managers now, because we have to tailor make what can this, in my tumor board clinic, when the recurrence happens, I ask, why did the recurrence happen? Oh, the patient couldn't afford this treatment. So it is very disheartening for us when we know what is the right technology to use, what is the right drug to use, but we are denied. So I think this is where we are muddling along in our country. But having said that, it is possible to establish systems, in answer to your question, to make sure they are not denied. So we have to do extraordinary measures like crowdfunding, foundation help. So we make sure, at least in our system, nobody is denied. And that was our Harvard case study saying, how is it possible you don't deny? For example, let us say a kid needs a CyberKnife treatment in the course of treatment, which costs about 5 lakhs. And you can say at 11 o'clock in the night, you come and take free treatment. Why not? Because CyberKnife doesn't require any out of pocket from us. So we have to create an architecture which supports this, for people who come into the system are not denied. That is the best we can do. Can we go and say whole nation has to change to meet this demand? Is a daunting task. But that is where government has to step in and say, hey, I understand. But there are governments in India who have done it. Like you take, for example, state of Orissa. Phenomenal development in terms of reimbursement. Phenomenal. They have been a leader. Pretty much what the private insurance pay, they pay for their scheme patients. So their patients are now getting, in my view, the best of care. We are trying to make it a model and present it to others to see, can we use this model? When Orissa can do, why not? So we are moving in the right direction to bridge that gap. Maintenance therapy, long term. But one thing I want to say as an oncologist for 48 years, really, we cannot say no to a patient. Doesn't matter, private, public, whatever. We have to come up for that patient a formula so that the patient gets the right treatment, not deny. And this is the constant battle for doctors, hospitals, everyone. But we have to say, okay, it will compromise maybe 0.1% of my margin. That's okay, let me treat. And I take, personally, I take a lot of pleasure because I have empowered as a doctor. May not be, everybody is not empowered. Suppose if somebody comes in and says, this patient wants some given discount. When I say discount or free treatment, I feel so good that I am empowered to do that. And my request is that let all doctors should be empowered in the system, private, public, to do that. I think that is bridging the gap and say, hey, man, I don't mind taking a cut in my profit. Let us do it for this patient. I think that is the fundamental norm we have to establish.
But does a private equity owning the hospital change that?
No, I think we have private equity. We are a listed company. I say, get lost. What are you going to do? Because doctors are the backbone. If the doctors stand firm and say, I'm going to do this discount, what are you going to do as a group? They can't do anything. I don't know any of the, because we have to believe in it and do. I am sure the administrators, managers also are concerned about it. They will come halfway and make sure it is done. Because I think, in my view, again, I'm going on a limb here, if I can, it is not correct to make a profit of 30%, 35% margin. No healthcare should. We should set a limit. Am I okay with 20%, 22%? Set the limit and do it. And if a private equity doesn't want to come, public are not interested, it's their problem. So we have to work on this. Some people say healthcare is your right in India. Some people say it is a must. Everybody should be met. We all talk. But are we practicing it? We have to. And who are our things who come in our way? Maybe the investors. We have to convince. In my view, I think majority of the investors, once you talk about it, will be convinced. We should not worry that much about the stock price, worry about what is the right for the patient. If you worry about it, stock price will automatically come. I think medical excellence, it will come.
Mr. Dilip, you're not listed, but but you do have a private equity which has taken over Manipal hospitals. So has anything changed for you all?
I knew that question is going to come to me soon after. I am telling you honestly, I knew the question is coming to me, and I was thinking what I will say.
I want that architecture of providing, compensatory.
No, so absolutely. I think all of us. I think there are many CEOs on this panel, and I think one thing that we all struggle with in healthcare is that, how do we say no to a deserving patient? For sure, not only at the, because what we should understand is no patient comes to the CEO. I don't think Dr. Ajay Kumar is a practicing doctor, but other than that, a CEO does not really come across a patient most of the time. It is a front-end hospital directors who like to face, take these decisions. I think one, of course, Ekta, we like to understand that it is important to ensure that a deserving patient is we make every attempt to see that a patient is taken care. But there would be a limit, unfortunately. I'm saying, oncology is one example. In a multi-speciality environment that, we come across so many deserving cases. Imagine a case of a polytrauma victim coming after a road traffic accident to the ER. Maybe the head of the family, head injury, and needs an immediate surgery. No insurance, no other support. What do we do? I'm saying every attempt is to see that we provide help, but unfortunate fact is that in all honesty, let me say that every element of the cancer care is expensive. That technology, the medication that is involved, and the people that are involved. I think every element of cost of delivery of cancer is expensive. So there is a limit to which we may be able to constrain, we may be able to reduce that. I completely agree that we may not require a 30% margin, but then for sustenance, we may require a 15 or 18% margin, which is fair enough. I think that has to be an understanding that a hospital sector, the environment sort of provides for it in the sense that there is price control, there are margin controls which are in play, which should ensure that over profiting is not done. But eventually, to the defense of everybody who's an investor, I must say India's healthcare sector has grown in the last 2 or 3 decades on the back of private equity investments which have come. It is not because of government investment. It is a private equity investment which has created technology, created beds, and reasonable returns are to be expected. What is reasonable, one can debate. But all I want to say, in the hospital, we struggle with this decision of who to say no to, and it is, we are in a cancer summit, but if you're in a cardiac summit, we'll have the same challenge. Somebody comes with a primary comes with an MI, would require a primary angioplasty, could save his life. Do we do a primary angioplasty? So I'm just saying cancer is a topic today, but in healthcare in general, we struggle with that query every day. We don't have an answer. It has to be that doctor said, a collective wisdom that, look, we need to have a limit on what we want to do.
All right. So that's on the financial aspect, but I'm going to come to the early prevention bit. And Dr. Datar, I'm going to get your thoughts in on this, because there's been a lot of focus in terms of how early prevention is the cornerstone of oncology. What is the progress that we've made when it comes to testing as well as early prevention? Something which probably doesn't even deter somebody from getting tested for preventive oncology.
So let me start off by saying, thankfully, Ajay and Dilip will not be able to trip me on the fact that I'm neither listed nor I do have external funding. So I fund my own activity, which is great. So I decide every Friday or Saturday not looking at Excel sheets, which is a true benefit as a clinician. It comes back to behavior. And I was talking to some of my Fortis colleagues yesterday that behavior starts with me. The change that we want to bring into early detection as a precursor is prevention. And in that space, it's at an individual level and it's at a systemic level, which is at a public health space level. At an individual level, how many of us start at 7 in the morning and end maybe at 11, 12, 1 in the morning? This is not sustainable as individuals, as doctors, as healthcare leaders. If I don't take care of myself, I can't take care of my company. And when we look at the way our behaviors have been modified over the last 4 or 5 decades, do you want to take a break? Do you want to take a chocolate? No, I probably want to walk out with my dog or play with my son as a physical activity in that space. Somebody brought up this point about processed foods in terms of what are we eating. The foods that we're getting into the system are not just toxins of the air that we're breathing. this aid of food coming into our kitchens now, which is pre-made, pre-processed in plastic containers, which we are reheating in a microwave. We just do not understand the damage that we are doing to ourselves as part of that ecosystem as an individual. So it has to start with me. Has to start with me, myself, my kitchen, my home, my workplace. That's the way I look at the individual subset of that place. Then you look at a systemic level, what are the major challenges that we have? We have good data to suggest that putting together a systemic plan of screening for breast cancer, for cervical cancer, to a large extent for prostate, for colon, and for lung, there is good data, but you will have to prioritize which are your major pain points today. You can't do it all. And you have to be extremely pragmatic, because you work within the structure of a country with limited resources and fundings, and we understand, we know what our GDP support metrics are towards the healthcare system, but it has to be put into prevention and early detection within that space. As long as you make sufficient amount of investments into educating, empowering various different populations across the diaspora of urban versus rural, I think this is really where that value is going to come in. And please understand that we are not even there yet today with regards to the standardization for the screening where there is data. The horrifying fact is that 60% of cancers and 70% of deaths come from cancers for which there is no screening at a global level. Forget us. So screening will create one element of support, but it has to be largely driven at a significant element by prevention. So we discussed a lot of things like tobacco. You have to walk the talk if you're looking at tobacco within the system, which is a significant insult, for example, for head and neck cancer, as one example in that space. When you look at various different dimensions, we spoke about earlier in the morning about mammograms, rural versus urban. What is the data? It again comes back to what are your gaps? If you do not understand gaps, you cannot fix them. So you need to understand across the country on a broad spectrum, which are the areas where you want to align goalposts to say, okay, I want to look at breast cancer reduction in this. I want to look at cervical cancer. I need to look at an HP vaccination program. I want to look at the fact that my uptake of pap smears is abysmal. How do I bring it up through education? How do I bring it up through women's empowerment? We are making changes with regards to sanitation, the Swachh Bharat, the toilets. That next element needs to be linked into this space. So this brings in what I do for myself and what I do at a country level across the second dimension. And I think the third and most important with regards to that process is also looking at providing access. It's important that we provide access across the ecosystem, especially for those where there's disparity in terms of that access of care. And that's going to be very, very important as we build into the technology. So we may talk about the fact that there are limitations even in our current screening programs. The mammogram itself comes with limitations. Yes, it'll miss some few cancers. It may create an issue of some false positives, but those are limitations of what we understand in the system. I always tell my work colleagues, when you're dealing with oncology, you are dealing with an imperfect ecosystem. You are not going to make it perfect tomorrow, but let's make it less imperfect. Let's take a step in the right direction to make sure we're not repeating the mistakes which others have made either in our country or in other countries. Let's look at, with our limited resources, what do we want to prioritize in that space? And screening has to be a significant element of it, because as everybody has said and everybody agrees, significant impact in terms of looking at downstaging disease. We want to capture those 3 and 4s at 1 and 2s.
So correct. Mr. Manchanda, what about y'all? What are y'all doing when it comes to early detection cancer screening?
So I think each enterprise has a role to play, and we believe that our role is not only to diagnose accurately, but also to help the ecosystem to diagnose early. I think a lot of efforts are actually going in that direction. I personally believe that for cancer, I think the biggest thing that we need to do, not only as an organization, but collectively, is just awareness. I think many of us have to play that role of educating patients or population in general. And also, I think the medical ecosystem, especially down the pop strata, also not fully aware about many of these things. So our role actually comes in when the test is prescribed. So we want to make sure that how early the test can be prescribed by a clinician. But clinician can only prescribe test if the patient actually goes to the patient, to the clinician. So I think it's awareness starting with the patient itself and then goes to clinician. And then as far as our own system is concerned, I think as I was mentioning to you this morning that we have a network of nearly about 277 labs, network of 5,000 collection centers and pickup points of nearly 10,000 or even more. Uh, so far, a lot of our testing was very centralized. Now I see that we have opened a lot of hub labs through remote pathology, digital pathology. So I visualize as an organization a pathology grid where the excess of testing is virtually going down the pop strata. Nearly about 35-40% of our business actually comes from smaller towns. So I believe one of the roles that we can play to early diagnosis to improve access of testing and at the same time put a layer of creating awareness in the ecosystem about early diagnosis.
I think it's also important to point out now the success of India when it comes to oncology. While we've spoken about the negatives and the burden, Dr. Raghuvanshi, we were just talking about before the session started about how many Indians who could afford it are now even probably not even going abroad for treatment anymore because of the accessibility that they have, the affluent has when it comes to cancer treatment. What is the progress that India has made when it comes to cancer treatment? Where are we when it comes to cutting edge technology versus, say, our peers in the US and Europe?
So a lot of change has happened in India, and the trend of people going abroad is becoming is practically gone away, and people are staying on in India. And the reason for that is that the accessibility has improved, the and all the cutting edge technologies are available within India. Whether it is on the radiation oncology side or it is on the specific gene therapies, or now CAR T-cell is also coming in a big way. A little bit of problem on the pricing of some of these technologies is there. It's still relatively high, but the segment of patients which is affluent and was going abroad can easily afford that. And even with the high price of import, it still is much more economical than going to United States or Europe for these treatments. So that, I think, is changing and quite rapidly. And another thing which has been happening is that accessibility, even in the smaller towns and rural areas, is improving. Today, the modalities of radiation are practically available across the country in large numbers. Maybe we are still deficient in terms of the gross numbers, but that is increasing. And the latest technologies at the same time are also available. Like proton is available in the country today, and MR-Linacs are available. So on the radiation side, also the latest technology is here.
Mr. Dilip, I just want to point out, I just want to try and understand one thing when it comes to India's oncology treatment. The waiting periods are much lesser as compared to what we see amongst our peers globally. When it comes to the UK NHS, or when it comes to the US, when you're covered under insurance, why is it that India is far more efficient in terms of a turnaround, despite the fact that we have such a so much larger population as compared to a couple of the countries we're comparing ourselves with?
Yeah, so Ekta, that's a great question. My own surmise of that is taking on from what Dr. Raghuvanshi has talked about, the access and affordability, that we look at the corporate hospital networks that we represent here. The patients who typically come to us are the ones who are either insurance covered or have the wherewithal to find the funding for their treatment. So what we should understand is every case that is detected or diagnosed does not automatically come to a hospital for treatment. So I think if X number is diagnosed, maybe 20 or 25% is first coming for treatment, and that is something that we are able to handle with the turnaround time. But I don't think we are diagnosing every case. I don't think every diagnosed case is seeking treatment. And if that were to happen, our turnaround time could get impacted. The second thing would be that maybe India is a little bit, unlike an NHS system or some of the highly insurance-backed system where there is a gateway and a filtering process. India does not have that. For example, in India, if somebody today wants to see a neurologist directly, you could go and get an appointment. But in a foreign system, you have to go through a gate. I think those would be the differences. I also want to, sort of add one point, if I may, to what Dr. Raghuvanshi was saying. One thing that we should keep in mind is India is a curatively oriented healthcare system. That it is a tertiary care and a curatively oriented healthcare system. What it means is people fall sick and then they come to hospital to get taken care. I think the way forward, I think the government recognizes it, everybody in the healthcare sector recognizes it, that we would need to be a preventive oriented or a wellness oriented society. I think that's the shift which has to happen if we are to deal with cancer, not only cancer, any other serious ailment, if it is a cardiovascular problem or any other stuff, that renal diseases which are really going up. I think the transition that the country has to make would be from a curatively focused kind of a network or a system to a little bit more preventive and wellness oriented system.
Okay, Mr. Manchanda, any thoughts in terms of how the private sector, such as even diagnostics, could collaborate with the government in order to probably expedite oncology care, expedite a focus towards wellness vis-a-vis curative?
Yeah, maybe I'll probably pick up this question after I have some views on what he mentioned. And the question that you asked about turnaround.
Tell us about the statistics in terms of a blood test or a biopsy report vis-a-vis our global peers as well.
Yeah, on an average, actually, we are 8 times cheaper than the test if you get conducted outside. And a lot of my friends who come from outside, they get their health checkups in India, actually, because it's much cheaper. So it's not only better turnaround times, but we are actually much cheaper. While we are perceived as an expensive healthcare ecosystem, but if you compare with Western world, we are way below that. So I think the challenge which I am seeing is much more humongous, because on one side we have a population of 1.4 billion, but the number of people who are seeking demand for healthcare is very less right now. And if I draw a parallel with air traffic, I think as the affordability improves, as the per capita income goes up, I am actually sensing a huge pressure on healthcare ecosystem, because the number of people seeking healthcare is going to blow up exponentially in few years from now. And as the awareness is picking up, as we are going to tier 2, tier 3 towns, I think the demand for healthcare is, you can't even imagine what is actually waiting to happen, what is coming in front of us. The next question is, how do we cater to this demand is a very big question. Fortunately, diagnostic is not a very capex heavy business. We don't require that sort of a capital investment as hospital ecosystem. I think the biggest challenge is on resources, both financials as well as on manpower or human resources, trained manpower. And the question that you asked is what role government can play or a private sector can play. I think there is a huge the entire network of government system, as I understand, there's a huge flow of OPDs in district hospitals. I think they are the places, feeder points, where if you do a public-private partnership and pick up cases very early, I presume this whole area of early diagnosis can actually be taken to the next level. So in my view, a public-private partnership in some of these district hospitals could be a good way to go about this.
Okay. Dr. Datar, artificial intelligence, that's seeping into medicine much more. Do you see it coming into oncology, into testing, into preventive oncology at all? And if so, how?
I think wherever there is data, you will find much more coming through very rapidly in terms of intelligently trying to decipher both gaps and benefits. Increasingly, we're seeing it in our space, which is in genomics, where more and more you are now looking at data subpoints, because as data evolves, you're also learning new things coming through that ecosystem. When you're looking at various different subsets already in Om's field, where digital pathology has already come in such a big way, you're already looking at various different intelligent metrics to define those. You can use them extremely smartly in the country. You can have a clearly defined hub and spoke model where you do not need to set up a facility in every nook and corner of the country. You can clearly look at creating smart technology interfaces between a hub and a spoke, where the spoke can benefit, and we've done this before. We've seen it work reasonably well across the ecosystem. I think the social strata and a divide as a healthcare ecosystem pre-COVID and post-COVID is very different. I think pre-COVID, regardless of whoever you and I spoke to, the patient always came back and said, no, I don't want to do a video chat. I want to sit across the table. And for some of those dynamics, you do not need it. Of course, you need it for a number of different phases where there's a physical examination to be done, other things to be done. You need to have the patient there. But what COVID, I think from a social standpoint of interface from the patient psyche has said, now it's possible. It's doable. And I think you have to leverage technology across different ailments and again, identify where will technology benefit. Clearly, AI will have serious challenges as well to bring into the ecosystem. I don't think we're there yet at a government level to look at a huge spectrum, but clearly there are spaces in which that is easily possible and doable. I think a lot of corporates are already looking at a lot of this data mining today, where they can look at it, and this is an enabler beyond oncology for sure. You are looking at it across the spectrum of healthcare sciences, where you can smartly use data mining, data drive across the system. And it is not a future to say that the interface and the future of healthcare is today clearly an interface between the clinician, the diagnostic space, whoever owns that space, the patient and the caregiver, and the fourth is the data person involved in this process. Because in all of those different elements, you will be able to identify gaps, plug those gaps, and also foresee in terms of future trends where can you use smart technology. And this will have an impact not only in terms of outcomes, but also in terms of cost of delivery, which is going to be so essential for us as a country.
Okay, well, Dilip.
For a change, I wanted to volunteer a comment on AI that, I had an occasion to participate in another panel with CNBC maybe 10 days ago on AI specifically. And, I just wanted to share a view that I hold very dear. One is that about 30% of all data in the world today is getting created by healthcare activities, that, hospital data and healthcare related data. And in India, I think every year about 380 crore OPD consultation take place, 380 crore OPD consultation, enormous number. So the data is very large, and AI has a potential, like Dr. Datta said, to really work on it. But I strongly believe that AI in healthcare requires guardrails. Unlike AI used in many other areas, I think in healthcare we are dealing with vulnerable people. Unlike consumers in the other sector, the mindset is different. When they come to a hospital, they are vulnerable people. And let's take an example of, we could have predictive diagnosis based on the data of a patient, longitudinal data of the patient, which hospitals have for the last 10 years, including that of his family members and all that. You might be able to, using AI, to give a predictive diagnosis. Look, you have a probability of developing this, not only cancer, something else in the future. I think as a hospital, we have to be careful in drawing a line that predictive diagnosis is not pushing him or her to do more tests, consume more healthcare. So that is where we have to draw a line between healthcare as a business and AI's role in that. I think that's the only point I wanted to make. It's a great tool, but we have to be careful with it in healthcare, and we would need guardrails on how we are going to use it.
Okay, so maybe a little cautious when it comes to AI. Dr. Ajay Kumar, let's wrap up the conversation by circling back to one of the points which were made. One about the lifestyle factors when it comes to the oncology risk in India. The fact that we have a lot of data which is Caucasian related and not India related, and hence what we need to take away as a population, as an Indian population, in terms of, say, the risk factors and the reason why we're seeing cases rise in the younger population. So if we could just sort of end the conversation with a couple of your thoughts on this.
Yeah, I think it's an important thing to understand today. Cancer is really an enigma. What we thought was cancer before is ever changing. By some standards, every 72 days cancer treatment is changing. It's a dynamic process because we are beginning to unravel the mystery of cancer. The heterogeneity of cancer. And today we know obesity or inflammation is one of the most important cause of cancer. When you look at it, it falls in the line of lifestyle diseases. When early days, we never understood what could be the relationship between cancer, diabetes, Alzheimer's, or cardiac disease. But there is enough evidence now in our own practice every day. There is such an interrelationship between these diseases. And what is the role of genomics? As we have heard, we are just beginning to tap the surface. That is why if some people ask, are you an expert in cancer? I say definitely not. It cannot be. One person cannot be an expert in oncology today. You need team. So when we look at it forward, why is it young people are getting cancer? What is it? Is it genomics? Is it environment? Combination of the both? Very clearly, it is combination of all this. For example, elephants don't get cancer. Why is it elephants don't get cancer? So there is a double P53 mutation, could be protective mechanism. How are we losing our protective mechanism? And once we lose, how long does it take to get cancer? And like we discussed previously, what is the body defense mechanism? And why is it, not all smokers don't get cancer? Only few get. And there is a reason behind it. What is the protection? How body is able to handle it? In some people, it cannot. Why? And also, cancer is such an enigma. For example, I always give this example: prostate cancer, which sits in the pelvic region, spreads majority of the time to bones. Why does it not go that much to liver or brain, lungs? We still don't know. What is the microenvironment? Whereas cervix, which in women sits anatomically same, very rarely goes to bone. Goes to lymph nodes and other organs. So we are just scratching the surface of understanding cancer. So we talk a lot about it. We say prevention, but global countries have tried prevention. Breast cancer incidence might have come down, but other cancers, colorectal, has increased. So it is not that easy an answer. Nobody can say, let us go for prevention, eradicate cancer. Cancer, I don't think can be like, can we say we are going to eradicate diabetes? It's going to be difficult. So that is why, what we need to really settle down for, we may not be able to cure. This is the dilemma of oncologists also. In the past, oncologists have done a great disservice to oncology. Diabetologists never said, I'm giving you palliative care. But oncologists were very good in saying, I'm giving you palliative care. So when a patient comes to you and you say, you're a stage 4, palliative care says, my God, forget it, man. I'll rather go to the burial ground. See, that attitude will be there. But if you say, I'm going to manage your disease. So we need to change our terminology, right terminology at the right time. And why should we use stage 4? Why not say your cancer is spreads to liver, lung? Why stage 4? Stage 4 means I'm already halfway through to Yamalok. So we should be very, very clear in our language, how we use, how others have done it, because cancer is now a chronic disease. If properly treated, even in advanced case, lung cancer, for example, breast cancer, it was unthinkable people can live for 6-8 years with advanced disease. So it is an ever-changing, so we need to change terminology that will give the positive approach. See, positivity is important, approach to the patients. Man, if I am like breast cancer, great, why not? Diabetes, why not? So that positive approach we have to reinforce. It has to be done by the media. How can media say corruption is a cancer of the society? What does the patient with cancer think? Please understand. So we have to be very clear in what lingo we use. So I think my experience, India has gone a long way in the last 2 decades. We have really leapfrogged. Sometimes, hindsight we will realize, but we have enormous progress in cancer care. We have to be positive. If a patient comes today and is living for 10 years, that's a great win over cancer. Chronicity. So we should appreciate and learn from it And as we understand Indian genomics, which is different from Caucasians, how are we different? What is it? As we analyze the data, streaming data every day, we are good in data. We are intelligent. We run Microsoft, Google, IBM, all the companies we run. We are damn good, intelligent, damn good doctors. You go to any center in the world, we are Indian doctors, right? You first go. So we are damn good. Let us use it in our country. Research, academics, bring together like this conclave. I'm very happy you're having. So we can all come together, understand the data, work as a group rather than individual institution. We can certainly win the war on cancer and make it a chronic disease.
All right. Well, on that extremely positive note, and it's important to point out that cancer is preventable and the narrative, changing the narrative is extremely important. On that note, we'll get a couple of questions in from the audience. So go ahead. You could get a mic there.
Actually more comments than questions. I think, God is very unfair to men. He loves women a lot. And you look at it in the field of oncology, women had cervical cancer as a problem earlier. And she would have post-coital bleeding. And she would blame her husband for it. And then that disappeared. Then we have endometrial cancer that become important. And that was manifest as intermenstrual bleeding. And that was something that was important and showed up. Again, breast cancer is something external and it showed up. And women had, for example, blood in their sputum when they coughed, and it again showed up. Whereas men, that prostate that is hidden there, that behaves very much like benign prostatic hypertrophy, which most men undergo as they age. There's a very little subtle difference between the cancer of the prostate and benign prostatic hypertrophy. Also, if you see colorectal cancers, these are two conditions which I, for example, as a family physician, I'm not happy really, I have to go and do a rectal examination and see whether this person has got a prostate problem or doing this. I may postpone it a bit. He has the same problem sometime back and say, okay, let him take the treatment for 1 week and see if he continues to bleed, then maybe I'll check him again. So what happens is, what we are seeing is that women have cancers which are external and therefore much easier to detect. I'm not saying not just a generalization, but because the important cancers are external, whereas in men, many of these cancers are internal. And another example that you can take is, for example, you ask anyone in the crowd here, I'll say about 75% will say they've had some bleeding in passing motion, sometimes the other. And almost everyone says that I've got hemorrhoids and things like that. And this can, as everybody knows, could be a symptom of colorectal cancer. And this is what we're missing all the time. And that's why this conclave is important for us to understand, beyond the proctoscope, which is just 6 inches long, that there is cancer beyond that. Having said this, I said, in India, we have a large incidence of tuberculosis. And a lot of our patients are bringing out blood. And that could be, for example, a symptom of, lung cancer, which we would miss because we have a high incidence of tuberculosis, and patients who've been treated for tuberculosis, who have relapses, who have multi-drug resistant tuberculosis and XDR tuberculosis, etc. The other area that one of the doctors has spoken about was about insurance. And he said, the blanket insurance that is there in the West is not here. But we also see in the West, doctor, there, for example, when you have a car and you take car insurance, if your car is buying a red-colored car, your insurance goes up. Because people with red-colored cars are known to be supposed to be a little sporty type, and they drive a little, and they're more likely to have accidents. The same way that if you have a system where our patients can be, have a system where, but if they have good lab test reports, they look good, those reports look good, physically they have the right parameters, and if they have, everything, the labs look good, that the people less likely to cancer, they don't have, other things, then it's likely that, we can reduce these incidence rates. Thank you very much.
Sure. Thank you. If we could just have 1 or 2 questions from the audience.
So that's just
Sir, your panel discussion has been very, very useful to all the practicing doctors. I just want to ask 1 or 2 small things. See, the number of cancer patients in India is much more than the population of many small countries, say European countries. At the same time, we have the largest number of doctors in the world. What exactly is causing so many cancer patients? Is it the increased diagnostic facility or increased in the incidence? what is the role of the pollution? And another point I want to make is, in a country like US, if somebody wants to see an oncologist or a oncosurgeon, he has to wait for about 1 or 2 months. Whereas in India, the patient can see the doctor the same day or the very next day. But at the same time, the prognosis of Indian cancer patients has been very bad compared with the rest of the world. Where do you think is the loophole and what is the solution?
I think, first of all, the prognosis in India is worse compared to West is wrong. When you collect the data, like we have done 4,000 breast cancer patients, the triple negative, compared it to my alma mater, MD Anderson. In fact, statistically, it's not significant, but on numbers, we look better. See, we are doing better outcomes for the stage, but we are not publishing it. That is why we think we are not good compared to global, but we are actually there. Our outcome, head and neck cancer, breast cancer, stage will definitely be equal or better than the West. In terms of us having more cancer, I think we are actually identifying cancer today in India. As I said, there is no Indian National Cancer Registry. Once we have a registry, county by county, district by district, it will help to analyze the disparity in cancer between different parts of India. Because India is a large country with different ethnicity. What is the cancer rate in Assam or Manipur compared to Bangalore? What is it compared to Gujarat? We have to really do a good demographic study, understand the oncology of India and why people are coming in different stages of what, and economics, the poverty or below poverty line people, what are the issues, why they are coming late. So all of this is as I said, is a task we are just undertaken. Why is it, we see Northeast as more head and neck cancer? Is it a perception or reality? We don't know the real answer yet. But all I can say is, as an oncologist practiced in US for 28 years and in India now, I see a tremendous progress. With technology, we can leapfrog to reach the global standard, and some of us are already there in big cities. I have no doubt about it.
Okay.
Thank you, Dr. Ajay Kumar. I think you've just answered the question that I was going to ask you next. This is primarily to do with data integration and how we can where we are currently, and how do we leverage that data in an actionable outcome manner to be able to even, as much as say, allocate our resources effectively that we have at this point of time. So if you could maybe shine a light a little bit on how you would see this pan out if you had to draw this plan up, in terms of even allocating our current resources so that we catch up with the shortfalls that we have, whether it be with upskilling, whether it be with just about getting the right things at the right place in the country.
Sure.
I think we are, like you said very well, what we were lacking is data. And when we do good work, how does anybody recognize? And other thing is with challenges. Because we are supposed to come from an emerging country, how will the advanced country take our data? Because we our own selves, we publish paper where Lancet says, the data is too good, it's coming from a third world. I have an email saying that. So it is because the West is now, they control everything, New England Journal, Lancet and all. For us to break through, it is not easy. We have to break through, but we have to establish our own journals, credible impact journals, and we have to come together to teach. Because I am convinced, doctor, patient coming through major institution in India are certainly getting even the turnaround time, outcome and all, far better than the West. Because I have friends in the West, I have patients, families and all, I know. I am convinced, but how to put it on data and prove is the task. That is where we should move forward. And resources are really not that much in India. It is technology is there, and putting the technology together, and whether it is EMR system, everything centrally collecting the data, we are doing that. We see 120,000 new cancer patients a year. How do we collect all the data, which head and neck and all that outcomes? I think it is a task which is, I think, a great journey for us to show to the world how we are doing extremely well, and we can challenge the world in terms of cancer outcome.
So I just want to extend this, what Dr. Ajay Kumar mentioned. I'm very hopeful that in next 10 years, this entire thing will change in India. The reason being mainly two, I believe. One is the commitment from the government side. You have this whole digital mission that's coming in, the entire repository of data in one place. Of course, an early stage, but that's one initiative. But second most important initiative, I believe, is that entire healthcare ecosystem in India is moving from individual practice to institution practice. And we are sitting here because Fortis as an institution, as a platform, as many of these platforms evolve in next 5-10 years, and with the AI and ML, I personally believe in next 10 years from now, we would only be talking about Indian data.
Just the last question.
Just the last question now.
So she has another one. Okay, two
Hello.
more. Just be brief.
How do you incorporate actually AI into person-centered or a patient-centered care? Because AI is all about data, and we have a collective data that machine learning and AI can actually pick up, which is there. But are we losing something on patient-centered care, which actually the doctor will deliver? I want the industry leaders to answer. And it's a wonderful podium here.
Dilip, if you could answer.
Yeah, I will attempt an answer there. One, of course, is we have to realize AI is always going to be a decision support system and not a decision making system. That, despite all the headlines which says AI is going to replace doctors and hopefully not managers, but with that that kind of comment. I'm saying hopefully that so I don't think AI, we should ever think of AI as something which will substitute the human judgment. I think in the Manipal system, for example, right now, we use an AI layer to run our radiology images through that, before it gets to a radiologist, it could highlight maybe 15 areas or 3 or 4 areas per image in terms of anomalies, just to highlight for the doctor to keep an eye on. And so therefore, AI could be a decision support system. I don't think it is going to replace. But the other factors in oncology, for example, Dr. Ajay Kumar was talking about personalized medicine or personalized treatment algorithms which could work for individuals. I think their AI could help the doctor, for these parameters of a particular patient. These are certain outcomes that other parts of the country had. It could throw out maybe a 15 or 16, whatever number of the treatment protocols that other doctors have followed had good outcomes, and have this particular oncologist decide if it is worthwhile in this case or not. So the bottom line is decision support, not decision making.
Okay, all right. Just the last 2 questions, really quick and brief, please.
So, if cancer is made as a notifiable disease, it will solve a lot of the problems. And secondly, we have, like say, for example, Arogyasri, lot of the other health schemes. In that already data is there, but nobody is coming out with the publications, say, publications of those data available, sir. So for that, we need motivated statisticians to be involved in preparing the data. Say, for example, if you see in Arogyasri schemes, we have a lot of data being treated for so many years, but we don't have proper statisticians who are preparing the statistics in how our patients are getting benefited out of the treatments.
Okay, all right. That point is taken, and maybe we'll just end with the
This is
lady.
the last question.
Yes.
Yeah, this
Please
is
go
a
ahead.
very important one for me, because I don't think I could get a forum like this to voice a very important issue that cancer patients and their families go through. I'm sure my fellow colleagues would endorse to what I'm saying. The emotional trauma that families go through is enormous. Suicide risk in cancer is 5 times more than the general and the psychiatric population. But seldom little is done for mental health vis-a-vis cancer patients. And I thought it wise, because you'll all be engaging with policymakers as healthcare delivery leaders as well as media, that if you can voice this concern with policymakers to make sure that the insurance covers this particular aspect, because mental health is not covered, and it's an out-of-pocket expenditure for patients and their families, and very often they kind of drop out of the psycho-oncology service primarily because of this important issue. Thank you.
Okay, well, that point is extremely important. It's not only the patient, but it's also the family that goes through it. And that is something that we had spoken about before the panel began, the impact of mental health and psych oncology, which is probably another aspect of it. But on that note, we need to wrap up. We're going to take the rest of the questions offline. Thank you very much, gentlemen, for joining into this panel. It's been a pleasure. Thanks very much.
Thank you to all the panelists and the dignitaries who have assembled today. If there is one takeaway, we will say that while the incidence of cancer is increasing, definitely our work and our technology, accessibility and affordability has to bridge that gap. And biggest takeaway will be that all of us as leaders in our respective ecosystems should work towards bridging that gap. So once again, thank you. And the stalwarts of the industry are with us in this journey, so we don't have to worry much. On that note, I'll request Dr. Ashutosh Raghuvanshi and Dr. Niti Raizada to kindly felicitate all the guests. They're taking a photo. Request Dr. Raghuvanshi to kindly felicitate Dr. Ajay Kumar, Executive Chairman, HCG Group. Big round of applause, please. Request for felicitation of Dr. Vineet Datta, Executive Director, Dattar Genetics. Dr. Raghuvanshi and Dr. Niti Raizada. Dr. Om Manchanda, Managing Director, Lalpath Labs. Mr. Dilip Jose, Managing Director and CEO, Manipal Group. Ma'am, please go. Thank you, Dr. Raghuvanshi. Thank you, everyone. And we'd like to felicitate Ms. Ekta Batra, CNBC TV 18 India Editor, Health and Life Sciences Vertical. On that note, we come to the end of the Healthcare Leaders Summit. Thank you once again to all of you. We now